I said CTEPH is one important part of that. That is group 4, and there is another group which is unclear, where or it may have a multifactorial causation, including systemic and metabolic disorders, which may be correctable in some cases. Next slide, please. Regarding manifestations and diagnosis, we don't have much time to deal with that. We have all learned from our postgraduate days that suspicion on clinical basis, confirmation by either an echocardiogram or a right heart catheterization, and finally scoring and risk stratifying these patients for further treatment is an important part of management of pulmonary hypertension. Next slide, please. We know that these patients usually present with, most importantly, fatigue. Some may have exertional dyspnea. The late symptoms, which are the red flags or which are the warning signs, are that of angina, which may be right ventricular angina, or syncope. That usually means that the PAH is of severe category, and these patients fare very badly as far as one-year mortality rates are concerned. We know from our undergraduate days that pulmonary arterial hypertension has very important clinical signs. For example, a loud pulmonary component of the second heart sound. You might have an ejection systolic murmur at the right upper sternal border. You might have a tricuspid regurgitation murmur at the lower left sternal border. You have parasternal heave. And in extreme cases, you would have signs of RV failure, including raised JVP, edema, ascites, hepatomegaly. And in some cases, you might have certain subtle clinical signs which might point towards a specific etiology for pulmonary arterial hypertension. Chest X-ray and ECG may only be indicative and not confirmatory of pulmonary hypertension. But you always have to keep a very high index of suspicion, because otherwise it is highly possible that you might often misdiagnose these patients and completely miss these patients in the earlier part of their natural history, and only when they land up in the later course would you be able to diagnose them later, when the outlook for these patients is very poor at that time. Next slide, please. Regarding diagnostic evaluation, I said you have to establish the diagnosis by echocardiogram or right heart catheterization. You have to identify the etiology, and then have to score them and risk stratify them to know about the severity of the disease. Next slide, please. Echo and right heart catheterization, the two pillars of diagnosis of pulmonary arterial hypertension. Echo is jolly well very good in most of the cases, because doing a right heart catheterization may be required in certain subgroup of patients only, because now echo monitors have very good algorithms. They give very good images to diagnose pulmonary arterial hypertension, to diagnose pulmonary vascular resistance. You have formula whereby you can easily get this data non-invasively with a good echo machine. Next slide, please. These are things we all know, that we estimate the pulmonary artery systolic pressure from the TR jet, the peak velocity. We also can get the mean pulmonary arterial pressure from the PI jet, that is the pulmonary regurgitation jet. We can get a mean pulmonary arterial pressure as well as the pulmonary artery end diastolic pressure from the PR jet. We can also estimate the mean pulmonary arterial pressure by the M mode of the pulmonary valve. These are complete chapter altogether, and we know most of these things, so I have not elaborated on the echocardiogram very much, because that is not the topic of discussion today. And looking at the effects of pulmonary hypertension on right ventricular size, the RV function, the systolic function, the diastolic function, the dimensions of the right atrium and the pulmonary artery, and the indirect evidence of pericardial effusion. These things also go in a long way in thinking about the diagnosis and confirming the diagnosis of pulmonary arterial hypertension by echocardiogram. Next slide, please. These are the, I said, these are some of the pictures that I've taken, where you can see that very good PR jet there. You can see the pericardial effusion, you can see the T-shaped compressed LV cavity, you can see the dilated RV, you can see the septal, paradoxical septal motion, you can see the inward drawing of the septum. These are all indicative of increased RV pressure overload and indirectly evidence of pulmonary hypertension. Next slide, please. Right heart catheterization is the gold standard for diagnosis of pulmonary arterial hypertension. We know we have already had these data before that the hemodynamic pattern will show a mean pressure more than 20. The wet pressure will be less than 15. That excludes the left heart disease, the group 2 of the WHO classification. And the PVR, or the pulmonary vascular resistance, will be more than 3 Mohs units. Also important to remember that with right heart catheterization, you can always do acute vasodilatory testing to see whether to decide your treatment modalities, which I'll discuss later, particularly with respect to calcium channel blockers. Next slide, please. Regarding etiology, this is a difficult domain because in many of the cases of pulmonary hypertension, the cause remains unidentified. Idiopathic pulmonary hypertension is a large group of patients, so you might not be able to find any etiology in many of these patients, but you should look for the important common etiology of pulmonary hypertension, including HIV, including connective tissue disease, left heart disease, congenital heart disease, parasitic infestations in minority of cases. Next slide, please. This is a busy slide. There are the pivotal tests are given on the left, where you can see that having a PFT or an overnight oximetry or a polysomnography might exclude a very important cause of pulmonary hypertension, reversible pulmonary hypertension, which is obstructive sleep apnea. Getting your HIV and ANA is important to exclude connective tissue disease. An important cause of pulmonary hypertension is portal hypertension. So in those cases, a simple liver function test might give a clue about portopulmonary arterial hypertension, and that might be good in many of the cases. And finally, right heart catheterization is the most important gold standard for diagnosis of pulmonary arterial hypertension. Next slide, please. It's very, very important that before you start treatment, to determine and risk stratify the severity of pulmonary hypertension, and that you can have from your echo. Echo will give you features of right heart failure, right heart pressure overload. All these things you can get in details from a good echocardiogram. Right heart catheterization hemodynamics will again give you a good idea about the condition of the right ventricle. Then you risk stratify and put these patients according to the WHO functional class by looking at the 6-minute walk test. And finally, you can also risk score these patients with a multi-parametric scoring system, which I'll come to in my next slide. Next, please. This is the WHO functional status. You have to remember that just as in angina and as in dyspnea, as in other cardinal symptoms of cardiac conditions, we have the NYHA class. In pulmonary hypertension, all the students have to remember this WHO functional class, because the whole treatment protocol is completely based on this WHO functional class. Depending on which class the patient is, the whole gamut of treatment is modulated according to the functional class of the patient, and this, I'd say, is universally applicable and is followed everywhere around the world, this functional class of WHO 1, 2, 3, and 4. Next slide, please. This is again a difficult scoring system. This is called the Reveal 2 score. It's a difficult score. It's a risk stratification scoring system. It's a good score, but there are many criteria according to this score, which includes modern investigations like BNP as well, but older investigations like echo, right heart catheterization, 6-minute walk test, the WHO subgroup, the demographics, everything is included within that. And also a very interesting inclusion is whether the patient has been hospitalized for heart failure in the last 6 months. Again, that is again incorporated within this. So this is a new score. It has come out only last year, but again, it's a very good risk score and can be used particularly in PH-specific centers where they deal with a lot of these patients, and this gives a very good idea about the overall long-term survival of these patients. Next slide, please. This I was saying, the risk assessment in pulmonary arterial hypertension, very important, very, very important, because you can see here that there is a vast difference in the 1 year estimated mortality, depending on whether the patient is low risk or high risk. For example, if the patient has repeated syncope, the patient is functional WHO class 4, has a very low 6-minute walk test of less than 165 meters, and his NT-proBNP levels are very high, then these patients are fare very worse, particularly if they have pericardial effusions, their hemodynamics are bad, their cardiac output is low. So these patients tend to fare very poorly compared to better low-risk patients where the hemodynamic parameters might be much better. Next slide, please. Coming to the last part of my discussion regarding the treatment of pulmonary arterial hypertension, I want to remind everybody that there is no cure for pulmonary arterial hypertension. It is a relentlessly progressive condition, but you have to remember that those who start therapy early demonstrates a better prognosis, and if you can treat these patients early, disease progression may be delayed. Next slide, please. This has been seen in many studies because as the functional class deteriorates, so the prognosis of these patients also deteriorates. But you can see here that almost 63% of all patients used to be diagnosed and functional class 3 when the prognosis is almost very dismal even during diagnosis. Next slide, please. So this is the survival correlation with the functional class. So as the class deteriorates, you can see the median survival comes down. And for class 4, the median survival is only 6 months, which is equivalent to some of the most malignant cancers that are present that we know of till now. Next slide. That there you can see the 1 year mortality is as high as 46% in class 4 patients. Next slide. These are the important goals of treatment: improving survival, improving the quality of life, and maintaining functional or improving functional class so as to reduce disease progression. What do we do for these patients? Next slide, please. This is the treatment algorithm of treatment for this patient. One is general measures and supportive therapy, where you can see it on the right top corner. Second is the vasoreactivity test to be done in class 1 patients only, that is in patients with pulmonary arterial hypertension, not with those who have pulmonary hypertension due to left heart disease or due to lung disease. So if that for those patients who are vasoreactive, calcium channel blockers are the way to go about it. And for other patients who are non-vasoreactive, you have many options which I have discussed at the end of my talk. Next slide, please. These are the important general measures, restriction of sodium, abstinence from smoking, oxygen administration, particularly in functional class 3 and 4 patients, for at least 16 hours a day, exercise training and rehabilitation for this deconditioned patient. But remember, excessive physical activity is strongly contraindicated in these patients. Pregnancy is a contraindication for these patients, particularly if they are in functional class 3 or 4. Adult vaccination against influenza and pneumococcus is important, and importantly, psychosocial support for these deconditioned patients is also very important. Next slide. The supportive measures I said about long-term oxygen therapy is important, particularly when the PO2 on arterial blood gas is less than 60. You might need to use diuretics judiciously in patients who have RV failure and fluid retention to achieve a euvolemic status. Anticoagulation should be considered in all patients with idiopathic pulmonary arterial hypertension. That is very important, as well as those who have familial pulmonary arterial hypertension. Correction of anemia and iron status is again very important. And it's very important to remember that any hypotensive drugs like AC inhibitors, ARBs, and beta blockers should generally be avoided in these patients unless they have compelling indications for their use. Next slide, please. This is what we will now talk about, that is specific therapy for pulmonary arterial hypertension. On the one hand, we have the calcium channel blockers, which is for the patients who are vasoreactive. And for other patients, we have a number of other now approved drugs, 13 approved therapies, which either are based on the nitric oxide pathway, the endothelin pathway, or the prostacyclin pathway. Let's see what these drugs are.
Arnab, please take care of the time.
Next slide, please. Right, I said about, next slide. Next slide, I said about vasoreactive study. It is very important to remember that in patients of class 1 pulmonary arterial hypertension, use of high-dose calcium channel blockers is essential. You may need to use up to 80 to 160 milligram of nifedipine in these patients to achieve adequate vasoreactivity and adequate improvement if the blood pressure allows you to use high doses of calcium channel blocker. Also, you have to remember that for functional class 3 or 4 patients, even though if the patients do not have good improvement, or if they have improvement with calcium channel blockers, these patients, in spite of vasoreactivity, might require specific PAH therapy along with calcium channel blockers. That is also very important. But the only precaution that I want to remind you is that calcium channel blockers are not indicated in patients who do not have a vasoreactivity study, or those with vasoreactivity study who are non-responders. In those, calcium channel blockers really do not contribute in improving the natural history of this disease. Next slide. This is, I said, if you have a long-term calcium channel blocker responder, you can see the survival is so good. The curve is almost a straight horizontal line compared to that when you have a failure or a non-responder, that these patients tend to fare very poorly in terms of short to medium term mortality. Next slide, please. Regarding non-vasoreactive patients where we need specific anti-PAH therapies, for the last 10 to 15 years, we now have a large number of new drugs which can be used in these patients with non-vasoreactive pulmonary arterial hypertension. Next slide. Next, we have already discussed this. These are the 3 important pathways as far as PAH-specific therapy development is concerned. On the left, we have the prostacyclin pathway. In the prostacyclin pathway, we have drugs which are either prostacyclin derivatives. We'll come to the drugs which are given either parenterally, IV, or subcutaneously, or we have the oral Beroprost, and we have the IP receptor antagonist, which has now been developed in last 3 or 4 years, which is a non-prostanoid IP receptor antagonist, which again acts like a prostacyclin derivative. In the middle, we have the endothelin pathway. We know that endothelin receptor A and B blockers. We have the bosentan, artesunate. These drugs act as endothelin receptor antagonists, and they also have very important role in PAH. And lastly, we have the phosphodiesterase inhibitors, which act on the nitric oxide synthase. And now we have the newer drugs, which is the SGC stimulators, which is a very important new drug, which acts very well on the guanylate cyclase enzyme, then thereby increasing the cyclic GMP production. Next slide, please. So these are the targets for current PH-specific therapy. I said about endothelin receptor antagonists, bosentan, ambrisentan, and macitentan. Then we have the phosphodiesterase 5 inhibitors, sildenafil and tadalafil. Then we have the guanylate cyclase stimulators, which is riociguat, which also works very well in idiopathic pulmonary hypertension, as well as in certain cases of CTEPH, where it has been shown to work very well. And on the prostacyclin pathway, we have the prostanoid prostacyclins like the epoprostenol, iloprost, and trepoprostenil. We also have oral beroprost now, and also I said about non-prostanoid IP2 agonist, which is known as selexipag, which again has a very important role to play in refractory PAH patients. Next slide, please. So there are two algorithms as far as specific anti-PH therapy is concerned. You might have a monotherapy or you can have a combination therapy. In combination therapy, you can either go with a sequential therapy, that is, you start with the first drug first, then you add a second drug for achieving even better results. But for those on high risk group, you might upfront use two of the drugs of two different classes together in this patient to get quick results. Next slide, please. These I said are the classes of drugs. These are the names of drugs and the important side effects. These are available in all standard textbooks now. And you can see the two important new developments are selexipag and riociguat are now in our domain, where we can use it along with the previous drugs of endothelin receptor antagonists, phosphodiesterase inhibitors, and prostacyclin analogs. Next slide, please. The choice again depends on many factors regarding the severity of the disease, how comfortable are you regarding the route of administration, patient prevalence, the side effect profile, and also importantly the cost consideration. Next slide, please.
Arnab, please come to your conclusion.
Yes, sir. I'm coming. 5 minutes more. These are the sequential combination therapies which are approved. The sequential combination therapy on the left side, these are the approved therapies, and these are the upfront combination therapy. You can combine an endothelin receptor antagonist with a phosphodiesterase inhibitor. You can combine prostacyclin analog with an endothelin receptor antagonist with a phosphodiesterase inhibitor also. These are the ESC guidelines, where you can either go for a sequential combination therapy or an upfront combination therapy. Next slide, please. But all the trials that I saw of combination therapy, all the important new trials in the last 3 or 4 years, not a single trial has been able to demonstrate any proven effect on mortality. All the evidence is in morbidity only. Next slide, please. There you can see that compared to monotherapy, combination therapy does not offer any extra advantage except for modestly increasing exercise capacity. Next slide, please. So, combination therapy improves the morbidity, but there was no effect on mortality. Next slide, please. So, the clinical assessment and follow-up of pulmonary arterial hypertension is also very important. So after you have the baseline scores with you, you follow up these patients after a 3 to 6 month trial of anti-specific PH therapy, and accordingly decide whether you want to go with a sequential therapy, or you want to continue with monotherapy, or you want to go with newer alternate drugs before switching to other modes. Next slide, please. I will not go into the treatment of pulmonary hypertension in specific conditions because that again is a big chapter in itself. Next slide, please. The only thing that I want to remind you is that use of specific anti-PAH approved therapies is not recommended in pulmonary hypertension due to left heart disease. So whatever drugs, the newer drugs that we have, the 5 classes of drugs that we have now, which I said earlier, is not to be used for other types of pulmonary hypertension like group 2 or group 3 pulmonary hypertension. It is only for idiopathic pulmonary arterial hypertension. Next slide, please. You can see here the trials of left heart with endothelin receptor antagonist and prostacyclins have all been negative. Next slide, please. Next. Next. So the only thing that I again said that off-label indication of sildenafil in patients with left heart disease due to pulmonary hypertension due to valvular disease should be discouraged. So I've seen many of my surgical colleagues in advanced valvular heart disease patients using sildenafil in patients who are waiting for surgery. I think European Heart Journal clearly says that use of this off-label indications of PH-specific therapies should be discouraged in this trial. According to this trial, which clearly shows that it really does not improve anything. Next slide, please. Next. This is about pulmonary, the previous slide. This is about pulmonary hypertension in congenital heart disease. Bosentan has been tried patients. About anti-specific pulmonary arterial hypertension. For CTEPH, for chronic thromboembolic pulmonary hypertension, we have surgical options. Very important to remember that these patients do very well with surgical pulmonary thrombectomy, and that is this mode of choice for these patients, and hence diagnosis of CTEPH by a VQ scan is important because then you have a specific therapy for these patients who are otherwise doomed to die. Next slide, please. Next. 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 This I said about medical management, non-pharmacological treatment of CTPH. Next slide, please. So this is my summary. There are a number of management options available for us in cases of pulmonary arterial hypertension. The role of spironolactone is still debatable. Anticoagulation is important, but does it really improve mortality? We don't know. Calcium channel blockers, diuretics, oxygen are proven therapies. Combination therapy of anti-PH specific therapies has been shown and proven to improve morbidity and even mortality in some cases of specific idiopathic pulmonary arterial hypertension. Pulmonary rehabilitation is important, and for end-stage disease, lung transplantation or best heart-lung transplantation may be the only option that may be available to these patients. Thank you very much. Next slide.
Next person.
Yeah, Thank you, Dr. Arnab. It was a very elaborate talk on pulmonary arterial hypertension. So I have a few things. I think even though right heart catheterization is not done routinely by most of us in India, but it has a very important role, and all patients of IPH should undergo a right heart catheterization at least once in their lifetime. But once you have Selexipag available in India, I think we also need to do repeated right heart catheterization before initiation and after monitoring the response to the therapy. The problem is that enough studies have shown that echo is not good enough to be sure of the number that you get of the mean PA pressure and the peak systolic PA pressure. That's one point. One question is that I think most of the studies are showing VQ scan as the primary modality to diagnose CT-PH and to rule out pulmonary thromboembolism as a cause of PH. So we often rely upon CT angio. Is it good enough, or should we do VQ scan in all these patients?
I think CT angio with the good the slices that we have. We now have 128 slice CT available even in small centers. So that is a very good initial investigation to diagnose CT-PH as well as pulmonary embolism very nicely, because VQ scan may not be available at all centers.
So one comment I want to make is that the number of strips of all these ERAs and the phosphodiesterase inhibitors sold in this country is much more than the number of IPH and Eisenmengers available in this country.
Absolutely.
So I think most of these drugs are absolutely overused.
Off-label use,
and I think they are harmful. Most of the studies have shown that they are harmful.
They are harmful. Most of the studies.
So that's very important point that you have made. And one more thing is that even though because of lack of time, you didn't cover about the non-pharmacological therapy. So what is the current role of balloon atrial septostomy and pod shunt?
So I can't hear you.
Balloon atrial septostomy and pod shunt in IPH.
Balloon atrial septostomy even in congenital heart disease PH patients is not very popular because of the may not be a good option because of the antecedent complications that are associated with the procedure, and maybe the only choice in when you have nothing really more available, then you might consider in end-stage disease patients. It's not a very easy option which is available everywhere, and not a very good procedure as such for all patients.
And your experience with pod shunt?
Sir?
Pod shunt.
Oh yeah, that's a much better option. That's a much better option, sir.
Kajol, unmute yourself.
Now can you hear?
Yes,
yeah.
Yes, sir, we can hear.
Yes. So you have done a very good job. You have covered everything, but few things I want to highlight. Recently, in the definition of pulmonary hypertension, ESC has included this pulmonary vascular resistance also, more than 10, but it has not come into the, you are right, in the textbook.
I think it's a good option, sir.
I hope shortly it will come. Systemic hypertension it differs from the systemic hypertension in the fact that systemic hypertension is a muscular hypertrophy. Here it is a subendothelial hypertrophy. That's why those drugs which are effective in systemic hypertension is not applicable to pulmonary hypertension.
Absolutely.
The investigations are very important. Apart from you have told also that is the one is X-ray chest, number is HRCT, thorax, and number 3 is the CT angio. You can diagnose most of the cases of pulmonary hypertension.
And now take off your finger from the lens. You are getting
Yeah. Yes. All right.
Yeah.
Now, last is the atrial septostomy. Yes, this is.
You are muted again. Kajol, you are not audible. Kajol, you are not audible and not visible. Yeah, I'm okay. Kajol, please complete your comment. Unmute yourself.
Am I audible?
Yes,
Yeah,
sir. Yes, sir. You are audible.
Yes, yes. Now, as I was telling, that the axial septostomy with implantation of a stent is coming in a big way. That is the last option in the management of pulmonary hypertension. Others you have all covered up very well. Thank you. Thank you very much.
Okay, thank you, the speaker and the chairpersons. I just have an important thing to announce. In the today's case presentation competition, the results are out. The winner is King. They are the winners and the runners. Congratulations to them. And we will personally inform them and will initiate the process to send their awards. They get a prize money of 60,000 for the winners and 45,000 for the runners.
Great, sir. Great.
And we will arrange to send them the money. Thank you. We will let us come to an end today. It is already, we are delayed by half an hour. So tomorrow we will start exactly at 12:30 and we need to stick to time. Otherwise, this thing cannot be completed within the stipulated time. Thank you very much. Thank you everybody for participating. All the delegates, speakers, chairpersons, those who have logged in, my thanks to them, thanks and gratitude to them, and I wish they will come again tomorrow. Thank you very much and good night. Good night.